Okay, we're live and ready to go, Senator Kelly.
Good afternoon, everyone. The Senate Finance Committee is now in session, and I'm going to suggest that our Vice Chair, Senator Feldman, serve as a co-host. Tammy, if you can make that happen for us. We're here this afternoon to get updates on very, very important programs. We were going to hear initially from the Maryland Insurance Administration, the Commissioner Kathleen Bahrain, Chief Actuary Brad Bobin, and David Cooney, the Associate Commissioner. And we probably ought to stop and take questions or have reactions after we hear them before we move on to the Maryland Health Benefit Exchange. And I think the very best member of our committee to serve as host, especially then, would be our Vice Chair, who works so hard to make that happen. So at this time, if the Commissioner is ready, we are.
Well, thank you very much, Chair Kelly. We appreciate the opportunity to present to you today. We'll start, with your permission, with a report on the individual non-Medigap and small group markets approved health insurance premiums for 2022 for ACA plans. So let me just start by saying that and reminding everybody that with respect to the individual market, the innovative reinsurance program that Maryland implemented has really worked. The goal of the plan when it was enacted in 2018 was to see a 30% reduction in the average rate in the individual market within 3 years, and then to see any future changes in rates be tied to the trend. Well, the reinsurance program was implemented in 2019, and it has resulted in a decrease of 32% on average compared to the 2018 rates. And this year, which is the first year where we would expect to be looking at changes only based on trend, while there was an increase in the average rate for 2022, the increase was actually below trend. So the rates for individual health insurance plans under the ACA, if you want to go to the next slide, Tammy. Thank you. So as the slides indicate, the rates for individual health insurance plans under the ACA will increase by an average of about 2.1% this year, even though the average claim trend is 4.4%. And dental insurance will go down just a little bit by about 0.1%. The amount that we approved was about 1.4% lower on average than what the carriers asked for, which amounts to about a $15 million savings. And on small groups, the plans under the ACA will increase by an average of 5.1%, which is just a little bit lower than the average claim trend of 5.7%. And with that, let me introduce Brad Bobin, who is our Chief Actuary, and Brad can walk you through the details about how we got to those numbers and what they mean.
Thank you very much, Commissioner. Thank you, Chair Kelly, for having me here today. This first slide is just, a brief discussion of the rate review process. By Maryland statute, we are reviewing to make sure that rates are neither excessive, inadequate, or unfairly discriminatory. In general, by actuarial standards of practice, we look at each individual assumption and check for reasonableness, and also are checking that all assumptions in aggregate are reasonable. Listed here are some of the major assumptions that we look at in rate filings. My predecessor, Todd, used to show this slide, and most of these have been on here. I'll draw attention to number 9 and number 10, where this year we're really dealing with the COVID-19 impact and also the impact of higher subsidies on the marketplace that under the American Rescue Plan and the state's new young adult subsidy pilot. in 2022, there's going to be a lot higher subsidy levels available. You know, as far as the timeline, rates were submitted at the, you know, on May 3rd, and we completed all our review on September 13th. If you could please go to the next slide. So this is a summary of the individual marketplace. As the commissioner noted, we've approved an average increase of 2.1%, which is lower than the 3.5% originally requested. As always, there's variance in that average. Different carriers requested different rate changes. You know, on a carrier level, the range was from -12.6 to +6.2. Within each carrier, there is even more variation beyond that. The other thing is that, you know, as the commissioner said, the 1332 waiver has been very successful. In aggregate, individual premiums are down 32% since 2018, even with this 2.1% increase. And that 2.1% increase is below trend. And a big driver of that is that the enrollment continues to grow in this segment. We're up to 222,000 members as of 6/30/2021. That's about a 4% growth from last year, which itself was a very good year for enrollment.
Tammy, could you go back one slide? Thank you. There you go. Perfect.
Thank you, Commissioner. I was looking at my own copy.
I think we're on page, actually, Tammy, we're on page 4. There you go. Perfect.
Thank you. And so this new enrollment in general has been younger and healthier than the people that were in the pool prior to the 1332 waiver. And so this has been helping to push morbidity down. And you know, morbidity, the average health status of the market, that was the big problem from 2015 through 2018, when rates were really, you know, increasing out of control, double digits every year. It was, you know, the population getting sicker, and now that is being reversed, and it's slowly getting healthier. One thing to note, that United Healthcare, under the legal entity of Optimum Choice, entered the individual market in 2021. They were in 14 counties in 2021. For 2022, they are expanding to the entire state, as well as offering additional plans. About 3,300 people have selected them to date. And while the new competition is good, and you know, having more options is a feature, there are some people whose advanced premium tax subsidy is going to be impacted by this. In counties where Care First was previously the sole carrier, that premium tax credit got inflated because of the way it is calculated, and United entering is going to bring that back down to the average level of the rest of the state. But there are some policyholders that are going to be adversely affected because of this. And as far as the benefit design goes, for the second year in a row, there's been very minimal changes to cost shares. That's been an issue in the past. You know, in the first year of the reinsurance program, even though rates fell, there was some substantial increases to deductibles, and it was noted at that time that you know, this was a problem, and you know, it's good to see that these have stabilized. Both the deductible and the out-of-pocket max have seen a lot of stability in the last 2 years. If you could move to the next slide, please. So as far as COVID-19 goes, in general, the aggregate impact of COVID-19 on the 2022 year rates is pretty modest, on the order of 1%. But there's a lot of offsetting things going on within that 1%. So as a background, you know, what happened when the pandemic started back in late March of 2020 was that carriers all experienced a very significant decrease in non-COVID utilization, that hospitals were canceling elective procedures, people were avoiding going to their doctor. And, you know, in March and April of 2020, non-COVID claims were down, you know, on the order of 40% plus from a normal level of utilization. And as 2020 went on, claims started to recover back up to their normal levels. And carriers are reporting that in general, aggregate claims are back up to where they would have expected by, fourth quarter of 2020, first quarter of 2021. So because of all this, when the carriers are setting their 2022 rates, they needed to make an adjustment to their 2020 experience to account for all of this depressed utilization that's not expected to happen again next year. And so carriers had to make an adjustment between plus 3.7 and plus 9.9% to offset this reduction in non-COVID claims. But that's not really driving the increase higher. That's just bringing the experienced claims back to what would have expected in a normal year without COVID lowering claims. An additional adjustment is that a lot of carriers are projecting that there's going to be a modest impact to future claims because of missed preventive services, that during that deferred utilization in 2020, people missed screenings and preventive medicine that would have caught and detected something. And that because of that, we can anticipate, worse morbidity next year, a sicker population on average. And that factor in general is on the order of 0.5% to 1%. And then there's also the possibility of additional adjustments for direct COVID related costs for, testing, vaccines, and treatments. As of the beginning of 2021, while aggregate claims are back to the normal claims level, you still have, non-COVID claims a little bit depressed from what you would have expected outside the pandemic, on the order of 5% decline. And then you have COVID itself accounting for about 5% of claims. So those two things offset one another. But, in general, carriers are projecting that COVID costs will decrease over time, that the hospitalizations particularly have peaked in, fourth quarter of 2020, and they don't expect hospital costs to be as expensive in the future. And in general, have not built in any explicit costs for COVID, additional COVID costs in the future. But this is something that they've all said that they're keeping an eye on, and that next year's rate filing could incorporate some more additional COVID costs. Next slide, please. So on the topic of premium subsidies, in general, in the individual market, a very large portion of members get the advanced premium tax credit from the federal government. Over 80% of people that buy on exchange, over 60% of the total individual market is getting subsidies. And so their rate increase is not directly impacted by what we approve for the unsubsidized rate. But rather their rate increase really depends on what the federal government does with the subsidy level. So the American Rescue Plan for 2021 and 2022 has significantly increased subsidies, reducing the post-subsidy premium by on average 40%. And this started back in May, I believe, is when it went live, and people were able to update their information mid-year and receive the reduction in premium. But last open enrollment, these higher subsidies were not in it. And so when you compare the 2022 open enrollment to the 2021 open enrollment from last year, people in general at all income levels between 150 and 400% FPL are going to be seeing lower post-subsidy premiums. And then on top of that, we have the young adult premium subsidy pilot, which is launching in 2022. And that only targets members ages 18 to 34. When you combine this subsidy with ARPA, these members on average are going to be seeing premiums 60% lower than they saw last year during open enrollment. And so, as I said, these subsidies tie into the rate development, that because there is such a lower premium point for subsidized members available next year, the carriers do project continued growth in enrollment for a third year in a row, and do project that enrollment should be, younger and healthier on average. I would say that they're projecting that the membership should be about 5% healthier. And in my personal opinion, it might be even more than that. Obviously, that's still to be seen. But, you know, this dynamic, even though we don't directly set the subsidized rates, this subsidized dynamic did come into play in the rate review and the rate development. Next slide, please. So these are just some numbers to show you the scale that we're talking about of the three different subsidies. The labeling is not the best here. You know, the leftmost column is what is under ACA. The middle column is ARPA, the American Rescue Plan Act, and the AYEA is the new state young adult subsidy. I cannot remember off the top of my head what that acronym even stood for. It was one of several pilot programs that we studied. What I wanted to bring out here is just, you know, if you walk across a certain row, like the 250% FPL, you know, under ACA, they were expected to pay 8.33% of their income, which translates to $224 a month for the second lowest cost silver plan. Under the American Rescue Plan, that's going to go down to 4%. And so they're only going to be expected to pay $107 for that second lowest silver plan. And that applies to all ages. And then for people ages 18 to 34, they're going to be expected to pay 1.5% of their income, which is $40 a month. And so, you know, the subsidy is calculated, it's backed into from these numbers. You first compute what a member's expected contribution is, and then compare that to the unsubsidized rate to compute the subsidy. But this just illustrates, you know, how much lower subsidized premiums are going to be for this coming open enrollment period. Next slide, please. So on the other marketplaces, I'm just going to briefly touch upon them. You know, in the small group market, there was an average renewal of 5.1%. You know, this is a little bit higher than the last 2 years where we had a 2.9 and a 2.2 approved. It's still a below trend increase. Small group trend is running a little higher than individual, higher utilization trend. It's at about 5.7% a year. And so, and just like for individual, there's a pretty wide range by carrier. You know, one carrier decreased rates by 26.8%. You know, that carrier has some of the higher rates in the market, and this is kind of an adjustment. And then, you know, the rate increases went as high as 9.4. In the small group market, enrollment has declined slightly. It's down 3% in 2021 after a 2% decline in 2020. The market stands at 255,000. While that's not great news, I can tell you that at the beginning of the pandemic, there was a lot of concern about the impact on uninsured that the pandemic could have, and a lot of modeling was done on what could be expected. And I know a lot of actuarial modeling were projecting that, you know, on the order of 10 to 20% of the small group market could drop their coverage and dump their people into the individual market / uninsured. And so the fact that we're a lot lower than those projections is once again pretty good news. And given all things, you know, this is a pretty stable market and continues to have stable rates. And then on the individual dental standalone market, we approved a 0.1% increase. That's the average. Only one carrier actually asked for an increase. In general, this market has been very stable rate-wise. Premiums in 2022 are slightly below the 2018 premium level. And that's without any benefit from the 1332 waiver and the reinsurance. And that stable premium has really allowed enrollment growth to start to grow pretty significantly. There was a 22% gain in dental enrollment last year, bringing the total up to 73,000. So now almost 1 in 3 members in the individual market also purchase a standalone dental plan. And if you could go to the next slide, please. Next one. And so this is just some more detail. This is the picture of what each carrier asked for in the individual marketplace. In column 7, you can see the rate increases that we actually approved this year. It's a 2.1% average. It's minus 12.6 for the Care First PPO entities, plus 1.2 for the United company, minus 5 for Kaiser, and plus 6.2 for Care First HMO legal entity. Column 8 shows the cumulative increases approved since the reinsurance program was enacted. And so that's the, overall 32% decline in premiums. And, once again, there's variance from carrier to carrier. And finally, columns 10 and 11 just show some sample premiums, to put a dollar amount on what these rate changes mean. And then next slide. Oh, this is a repeat. I apologize. This is supposed to be the small group data, but I accidentally put the individual data in twice. We do have, as part of our press release, this level of detail for the small group data. If anybody needs that link, please contact me and I'll share that link with them. Sorry, I messed up that slide. So at this point, I don't know if we want to move on to David or if we want to take questions now on the rate portion.
Okay, are there questions? Okay, I guess we can move on to David.
All right, thank you.
So we'll move on to MAPIA, so our mental health parity work, and just wanted to give you a brief update on where we are with the regulations. Just to remind you, next slide, please, Tammy. Thank you. So just to remind everybody that pursuant to 15.144 of the insurance article, on or before the end of this year, the Insurance Administration is required to promulgate regulations that would create standard forms for carriers to submit reports to demonstrate their compliance with the Mental Health Parity Act, the federal act, create a summary form for carriers to post information from the reports to their website so that there's public accountability. And then in consultation with interested stakeholders, we are adopting regulations that will ensure uniform definitions and methodologies for those reports. Next slide, please. So to that end, we have held 3 public meetings and we've requested written comments focusing on the NQTL reporting requirements under the statute. We've engaged with various experts and stakeholders to research and develop draft regulations and reporting form templates and instructions for completing the forms. David Cooney, who's our Associate Commissioner for Life and Health, will walk you through what occurred in each of our 3 public hearings, and then I will sort of summarize for you where we are currently.
All right, thank you, Commissioner. Tammy, if you want to go ahead to the next slide. So I'm going to, as the Commissioner said, go over what we did at the public meetings and a little background for what we're doing in between those meetings. So as anyone who has spent any time working on mental health parity compliance will tell you, it is an extremely in-depth and complicated analysis. And it was very clear as soon as we started this project that it was going to be absolutely critical for us to standardize the reporting process and provide carriers with clear guidance up front as to the level of detail and documentation that would be required to show compliance. So that was our goal through all these efforts, was to develop standardized reporting forms with very detailed instructions that'll ensure the initial filings we receive from carriers are consistent, complete, and comprehensive. Ideally, this will minimize a lot of the follow-up investigation and back and forth correspondence that we've experienced in the past with our mental health parity analyses. And then it'll therefore make it possible for us to fulfill our statutory obligations of reviewing these reports in a timely manner and reporting the results back to the General Assembly. So when we started our initial work of developing the standard form for the NQTL analysis report, and just as a reminder, NQTL stands for non-quantitative treatment limitation. It's essentially any kind of limitation that's applied to mental health and substance use disorder benefits. So when we started our work, we had to take into account uncodified text from the statute. And that text require the MIA to use the NAIC data collection tool for mental health parity, and then to make any necessary amendments to that tool to incorporate the requirements of 15144. And now this was a compromise that was reached between all the stakeholders when the bill was being debated during the 2020 session. So when we held our first public meeting on November 23rd, the main topic was identifying which particular NQTLs would be most appropriate and precise for demonstrating parity compliance as our first step in determining whether or not amendments would be needed to that tool. And the NAIC tool itself references 13 different NQTL categories. So as you can see from the slide, we heard presentations, 3 formal presentations, followed by comments from other registered speakers. Milliman, the Path Forward for Mental Health and Substance Use for the Mid-Atlantic, and the Bowman Family Foundation all presented. And they, along with the other speakers, provided very helpful context, insight, and recommendations that we then considered. And we can move on to the next slide. So following the November public meeting, we considered all the oral and written comments we received, and we reviewed them in the context of the legislative history and the intent behind 15144. We also continued researching and analyzing the actions of other states with respect to mental health parity, and we tracked all the developments at the federal level. There were very significant changes in federal law and guidance that had occurred during this period, and these provided much greater clarity on what was expected of carriers in order to demonstrate compliance with the federal parity requirements. Specifically, the Consolidated Appropriations Act of 2021 included a section that expressly required carriers to perform an NQTL analysis that was very similar to that which was already described in 15144. And then a few months later, a federal FAQ with even more guidance was released. And of note, that FAQ indicated that the Federal Department of Labor would be focusing its enforcement efforts on only 4 NQTL categories. 3 of those categories were already included among the 13 from the NAIC tool, but the 4th category was not, and that was reimbursement rates. So after considering all these developments, we determined that we should limit the report to the 13 categories of NQTLs that were included on the NAIC tool, and then also add reimbursement rates. So we then convened our second public hearing on April 26th to receive comments on this proposal. We can go on to the next slide. So between the April public meeting and the August public meeting, all of the background research and preliminary drafting work that had been ongoing really came together with our first public drafts of the materials. Pre-publication draft of the regulations was posted to the MIA website for public comments on July 30th. And the regulations, primarily what they did, it defined the key terms. It established the requirement the carriers must use the standard forms and associated instructions that will be posted to the MIA website for filing the reports. And it also provided criteria for what is considered a complete report. And this last item was important because the statute authorizes the commissioner to impose penalties for failure to file a complete report. And this is really an enforcement mechanism intended to put pressure on the insurance companies to perform their due diligence up front. So then the following week, the draft template forms for the reports themselves, along with the detailed instructions for completing those forms, were posted to our website on August 6th. The MIA staff had spent significant time and resources researching and comparing the efforts and reporting tools of other states, the Federal Department of Labor, and various private stakeholder groups. And we attempted not to reinvent the wheel, but really just to pull the clearest and most useful guidance from those other sources that we could find. And then we further clarified it anywhere where we felt that was appropriate. So the instructions for completing the template forms were really kind of the most important part of this whole process, because our own past experience, as well as what we learned from other states and the Department of Labor, revealed that carriers really need very clear and specific directions up front about what must be submitted to demonstrate compliance. Otherwise, many carriers end up providing just general conclusory summary statements that essentially just restate the legal standard without providing supporting evidence and a detailed explanation of any analysis that was actually performed. And then when we get those, it just starts the whole back and forth process again. We have to keep asking for more and more information. So for this reason, the draft instructions that we have posted, they provide examples wherever we can of what is sufficient and, more importantly, what is not sufficient to demonstrate compliance. So we feel very confident that our initial drafts that have been exposed for public comment already represent a very good product. And then we convened another hearing on August 30th, 2021, where we received oral and written comments on all those draft materials to identify any areas where the materials can be further improved. And with that, I'll turn it back over to the commissioner to go over our next steps.
Thanks, David. Thank you, Tammy. So just briefly, following the August 30th hearing, we did make some revisions to the regulations based on the comments that we received from stakeholders, and they have now been submitted for publication. The MIA took the approach of having the forms and the templates themselves referenced in the regulation, but being activated by bulletin separately. So we are continuing to work on the templates and the forms themselves, reviewing the comments that we continue to receive from various stakeholders. And we anticipate that we will be posting the revisions on the MIA website within the next several weeks, with the intent of holding a fourth public meeting in early November to talk about that next iteration of the templates. And you can certainly use that link to catch up with the most recent versions that have been published. And that is the status of where we are with the MAPIA regulation, and we're happy to take any questions that you might have.
Senator Augustine.
Thank you, Chair Kelly. I just wanted to say that as the sponsor of this legislation, that I really am grateful for the work that MIA has done on this and continue to work with in partnership with them on the development of this tool to help with the compliance with the federal law. And also, as I mentioned, just tracking what's happening on the federal level and the fact that the carriers are going to have to track all of the NQTLs, TLs, which will have an impact on this. And that we'll just continue to look for this process to develop. And I just really just wanted to share that I want my thanks for their work on this. Thank you.
Sure.
Thank you, Senator. And if I may just say, I wanted to make it absolutely clear to you and to every other member of the committee, while we have focused on the 14 NQTLs with regard to this formal biannual reporting process, we are ever mindful of the fact that carriers are obligated to address all of them. And our general regulatory oversight powers, which we have used and will continue to use, give us the ability to look into those NQTLs, which may not be the subject of industry-wide biennial reports.
Thank you. I appreciate that.
Thank you. All right. Seeing no other hands, are there other questions or comments? Okay, thank you very much for the very detailed report and for the handouts, and whichever thing it was that was missing, if you could get to Tammy or to our analysts with a copy, we'll get it out to anybody who wanted that updated or missing report. Thank you so much. Okay, so we're going next to the Maryland Health Benefit Exchange. And we have Michelle Everly, Joanna Fabian Marks, and I'm not sure in what order you guys would like to go.
Chair Kelly, I'll start. Thank you. And thank you, Chair Kelly and Vice Chair Feldman and committee members for having us here today to provide a briefing to you on the reinsurance program and the young adult subsidy program. As you know, the reinsurance program has just been wildly successful. It's put us in a very prominent position in the nation, and our success has just been super over the last several years. So great, in fact, that in 2019, we saw an increase in enrollments of 2%, in 2020 of 1%, and in 2021, in the midst of the pandemic, we saw enrollment increases of 4%, particularly in those individuals that have over 400% of the federal poverty level. We saw a 6% increase. And that was the group of folks that really had been priced out of the marketplace because they weren't eligible for any subsidies or tax credits. So we've had really tremendous growth. Not only has the growth in total increased since 2019, but particularly in some of our segmented communities that we've really tried to increase enrollment, and particularly in our Black community, where we've seen enrollment increase 8%. And that's been really targeted outreach where we've tried to communicate and get information out. The average premium in 2021, you heard from Mr. Bobin about the premiums for next year, but the 2021 premium, we actually have the third lowest premium in the United States before tax credits. So that's just tremendous. It's 23% less than the national average that we're able to offer Marylanders. And what we've seen, and you heard about this with the risk profile, we've been able to increase and hold steady the 18 to 34 age group at 28% of our enrollments, which is just terrific. So that's a little bit of the success that we've had in the reinsurance program. I'm going to turn it over to Johanna Fabian Marks, who will speak not only more in depth about the reinsurance program, but also about the young adult subsidy.
Thank you, Michelle. And thank you, Chair Kelly and Vice Chair Feldman, and we can proceed to the next slide. So I'm Johanna Fabian Marks, as Michelle mentioned, Director of Policy and Plan Management at the Exchange, and you can see our agenda today on the screen for this portion of our presentation. So I'll start off by providing some quick background on the reinsurance program, an update on the program's performance, which you've already heard a lot about, and then I'll review the program's actual and projected cost and enrollment data, and I'll wrap up that section with covering the timeline for a potential waiver renewal and sharing some high-level information from our first round of carrier accountability reports. And then I'll end with an update on the implementation of the first year of the 2-year pilot Young Adult Premium Assistance Program. We can go to the next slide. So this will start the section on the reinsurance program. And on the next slide, you can see just a quick background. I know you guys are well familiar with this, but just as a quick refresher on how the reinsurance program works, it operates under a waiver from the federal government. And it reduces insurance premiums in the individual market by covering a subset of insurers' claims. Because premiums are lower due to the reinsurance program, the federal government spends less money on their federal premium subsidies, and then they pass those savings on to Maryland to spend on the reinsurance program. So I'll refer to that as federal funding or pass-through funding. In the chart at the bottom of the slide, you can see that the MHBE board has chosen to hold the program parameters constant since the start of the program. So for people who have more than $20,000 in claims per year, reinsurance covers 80% of their claims up to $250,000. On the next slide, I'll move on now in this section to reviewing some data on the program's performance today. I won't spend a lot of time on this. You heard this from Brad, the commissioner, and Michelle, but monthly premiums are down more than 30%, as you've heard, and enrollment is up significantly since the program launched. And there's some more detail on that in these charts, but we've all been sharing those numbers with you, so I won't spend too much time on them. On the next slide, this is just a little bit more information on how our premiums compare to national averages. Michelle mentioned that in 2021, we had the third lowest average premiums for on-exchange plans nationally. Here on the graph, you can see Maryland's premiums by metal level in the solid line and national average premiums in the dotted line. And you can see how our premiums have fallen by about 20 to 30% since the program launched compared to those national averages. So just more testament to the effectiveness and success of the reinsurance program. On the next slide, I'll move into reviewing some data on how much we're spending on the program, how that fits into the overall market, and our funding projections. So this slide shows, you can see across the top in bold, that in the individual market in total, claims in 2020 were about 1.2 billion, and that was for about 212,000 enrollees. And that's both on and off exchange, so the total individual market. The pie chart on the left shows that only about 6% of enrollees, that sliver in green, met the threshold to qualify for payments under the reinsurance program, meaning they had more than $20,000 in claims in 2020. The other 94%, the majority in blue, had less than $20,000 in annual claims. On the right, you can see that the 94% of enrollees in blue who didn't qualify for reinsurance payments accounted for about a third of claims. So 94% of people, that's accounted for about a third of spending. The 6% of enrollees who qualified for reinsurance payments accounted for about 2/3 of claims. And you can see that those claims are shown in dark green and light green. The reinsurance program reimbursed about half of those claims, as shown with the dark green wedge, and carriers paid the other half of those claims. So in summary, that about 6% of enrollees that qualified for reinsurance claims accounted for about 2/3 of claims in the individual market. And of the claims for these high cost enrollees, the reinsurance covered about half, which works out to about a third of total claims in the market. And this data is pretty consistent with what we saw for 2019 as well. If we move on to the next slide, we have some information on our financial projections for the program over the next several years. And I'll start by saying that the last two columns on this slide, both for 2023, present two possibilities. So first, that the American Rescue Plan ends as scheduled at the end of 2022, which is what current law is. And second, and the last column on the slide, that the ARP continues past 2022, which is currently under debate in Congress. As Brad mentioned, the ARP increases federal funding for subsidies for 2021 and 2022. That has a kind of side effect of increasing our federal funding for the reinsurance program. So if the ARP ends in 2022, that would lead to a lower amount of federal funding in 2023 compared to if Congress does decide to extend it. So on to explain what you're looking at here in this chart. We've got program outflows in red at the top. If you'll just click Tammy, you can see that top column that's highlighted is the actual or projected cost of the program, depending on the year, whether we have actual numbers yet or not. You can see that grows to about 500 million in expected costs by 2023. If you click again, you'll see that the second set of numbers with the dark red shows other draws on reinsurance funding, apart from just paying claims under the program. These were passed in the most recent budget. So these are amounts that are being pulled from state funding because we're not allowed to use federal funding on anything other than reinsurance. So these state funds are supporting some other state programs, including the budget transfer was a transfer to support the Medicaid program. Then we've got funding being used to support the Young Adult Subsidy Pilot Program. And then we've got funding being used to support the Health Equity Resource Zone grants. If you click again, you'll see that in the middle in green, we've got the incoming funding to support the program. The first green row shows actual or projected federal funding, and below that we have state funding generated by the state premium assessment to support the program. So you can see federal funding makes up the majority of the program funding, and state funding is estimated at around about $120 million a year. And then if you click once more, you'll see highlighted at the bottom in blue, we have our anticipated year, looking separately at federal funds and state funds. So once we've spent the money that is going out in red and we've got our incoming funding in green, this is where we end up at the end of the year. You can see that in the first couple years of the program, federal funding exceeded the program cost. So we were left with unspent federal and unspent state funds. And we expect that to be the case this year as well. However, under current projections, as we look out at future years, we do not expect to carry forward unspent federal funds. So we expect to spend our full amount of federal funding, and then we'll be drawing on our state dollars to support the program. Under our current projections, we expect to end the current waiver period, which is 5 years and ends at the end of 2023, with about $200 million still remaining in state funds if the ARP ends, or about $261 million if the ARP continues. And that's, as I mentioned, if the ARP continues, we anticipate higher levels of federal funding, which leads to that higher balance at the end of 2023. And just one quick note, this slide does not break out our program admin costs, which are nominal. In 2020, they were about $100,000 and are paid out of federal funds. So I just wanted to note that in case anyone tries to recreate the math at home here and notices some small discrepancies. And then if we go on to the next slide, in this next portion, I'll just briefly review some information about the reinsurance program renewal timeline. So on the next slide, you'll see a chart. The key dates to be mindful of here are that the actions we're required to take by the federal government are to submit a letter of intent indicating our intent to extend the waiver, and then to submit a waiver amendment or extension application. So as I mentioned, the waiver is currently scheduled to end at the end of 2023 because the federal government approves them for 5-year periods. And so if the state chooses to extend the reinsurance program, our two key dates are that we would need to submit our letter of intent by next October 2022. And then the application would need to be submitted by March 2023. The key action at the legislative level that would need to be taken to facilitate extending the program is a determination of whether to extend state funding for the reinsurance program. The state funding, the assessment that I mentioned previously, also sunsets at the end of 2023, and per federal requirements, to receive the federal waiver, we need to be able to demonstrate a source of state funding that will support the program. So ideally, that determination would be made in this upcoming legislative session, which would then set us up to submit the letter of intent next summer or fall, and then proceed with submitting the application by March 2023. On the next slide, I've just got a final quick section here that I wanted to share some data with you on our carrier accountability reports. So this is a set of reports that we established in regulation that we require carriers to submit annually to describe what they're doing to manage the cost and utilization of enrollees for whom they're getting claims reimbursement from the reinsurance program, and what they're doing to try to contain costs and improve quality so that enrollees don't meet that $20,000 claims threshold in the first place. The first annual report covered the first year of the reinsurance program, 2019, and that is our baseline. And then our 2020 report will enable initial evaluation of the effectiveness and savings from these carrier activities. So we have the 2019 report. We recently got the 2020 report. So I've got some preliminary information from the 2020 report, but we're still analyzing that. On the next slide, you'll see listed a few targeted conditions that we collected more detailed data on. And we did that in consultation with other state agencies to identify state population health goals, which focused around these 4 conditions: diabetes, behavioral health, asthma, and pregnancy and childbirth. So we collected targeted information on those 4 conditions. On the following slide, you can see a chart showing some high-level information on the carrier's care management initiatives in each of these 4 areas, as well as the percent of people who ended up getting reinsurance payments who were engaged in these care management programs. So you can see that the 2 carriers here, because United was not in the market in these years, had care management programs for diabetes and behavioral health, so for 2 out of 4 of the targeted conditions. And those programs enrolled anywhere from between about 20 to 50% of members who ultimately got reinsurance payments. On the next slide, you can see what the top conditions were among reinsurance claims. So we collected data on what conditions were most frequent among people who were getting payments from the reinsurance program, and what conditions were the highest cost. You can see various cancers were the highest cost conditions in both 2019 and 2020. Highlighted in blue are conditions that fell into our targeted condition list. And actually all 4 conditions, I believe, were in the top 10 or so conditions. So we did, those did end up being good selections to collect additional data on, but here on this slide, we're just showing the top 5. And you can see that diabetes, one of the state's leading public health priorities, was among the top 5 most frequent and most costly conditions among reinsurance enrollees in both years. So on the next slide, we just briefly cover what our next steps will be with this. We're going to, of course, complete our analysis of the 2020 reports, and then use these reports as a basis for conversation with carriers about their care management programs and initiatives. And we also plan to explore how we can encourage and work with carriers to align their care management activities for individual market enrollees with our state population health initiatives, and focus on conditions that are driving our reinsurance program payments. And that's something that we're certainly plan and are closely collaborating with other state sister agencies on. And then the next portion of the presentation, I'll just wrap up with a quick update on the Young Adult Premium Assistance pilot. So if you go on to the next slide, you can see some updates on key elements of implementation, including establishing our eligibility and payment parameters. So that occurred this spring. Our board set those, both proposed standards, took public comment on them, and then finalized those parameters in May. We're in the process of finalizing regulations for the program. Those are currently published as proposed, and we're on track to finalize them by the end of the year. And then from a system standpoint, the Young Adult Premium Assistance will be displayed on our website during open enrollment, and it will be automatically applied for eligible renewing enrollees. And that's it for the presentation, and happy to take questions.
All right, are there questions? Senator Feldman.
Thank you, Madam Chair. First of all, let me thank the Exchange. They just celebrated their 10th anniversary, actually, Madam Chair. And I also wanted to, I know you're a former academic, so as you know, I teach at the University of Maryland College Park, of course, on healthcare policy, and my guest lecturer tomorrow night is none other than Michelle Eberly. And I told my students they can get some extra credit by watching the briefing today. And if they throw some tough questions at her tomorrow night at College Park, Madam Chair, they're going to get some extra credit. So I just want to throw that out there. But back on the hearing and a couple of questions. So I just want to make clear, and this would be for Joanna or Michelle, like we have to pass legislation in terms of the extension or the continuation of the reinsurance program, we have to identify a funding source, right? And we'll have to pass a piece of legislation in the 2022 session. I mean, there's no doubt about that. I just want to make that clear for all the members of the committee, right? Do I have that correct?
You could wait till the next year, but it would make it very, very difficult, and then we'd be really up against a tight timeline. So I think this is the year to do it in the next session.
Okay. On the young adult subsidy program, I mean, I'm excited that we got the bill out of the committee and it's a 2-year pilot. One of my concerns, and not a concern, I know you mentioned that you'll be promoting it on your website. I think that for the committee, and this would be true of HDO too, I think, the legislators who worked on this, we would love to help to promote it as well. I mean, is there going to be, beyond having something on your website, is there something you can provide to members of the finance committee, for example, and I would say the same about HDO, that would allow us to distribute to, our lists on social media that we have this new program. It's a pilot, but it's, potentially going to be extremely helpful for this 18 to 34 group, help them get health insurance. Is that something that's part of the marketing plan for us as well?
Johanna, you want to talk about some of the marketing efforts?
Sure, yeah. So just in terms of that specific element, yes, our marketing team is developing what they call partner resources, which include Facebook posts, Twitter posts, blurbs that can go into a newsletter that can be easily kind of lifted and used by folks who want to help us promote it. So once we have that up, it'll be sort of a dedicated space on our website where you can access all those materials, and we'll be sure to send that out. And in addition to that, we have a broad marketing campaign plan that includes TV, radio, print ads, partnerships that will all be focused on promoting.
Okay, because I keep reminding folks that it is only a 2-year pilot. People seem to have forgotten that at the end of the 2 years, we're going to hopefully, it'll be a big success, and then we can have the data. And other states actually have been asking about this program too. So we'll have a report that could be maybe, I know Massachusetts has had this in place for some years. So we want to do it right, and marketing, I think, is really important part of it. Thank you, Madam Chair. And Michelle, I'll see you tomorrow night. Bring your A game.
Okay, sure will.
Okay, and we thank you for the work that you do as co-chair of the commission. Did I see your hand up before Senator Hayes? Okay, are there any questions? Well, you guys did a great job, and we're happy, and we do want to help. Okay, if not, then I guess we will thank our guest presenters for doing a good job and for explaining to us the good job that you're doing. And remember that we do want to be helpful, so think how we can butt in and do our part. If there are no other questions, then we will call it a day. And thanks so much, everybody.
Hey, Madam Chair,
yes,
Madam
yes.
Chair, just real briefly, just want to remind the committee that we have another briefing tomorrow at 1 o'clock on the calendar on Medicaid related issues. And so before we adjourn, I just want to remind the committee that we do have a briefing on Medicaid related issues tomorrow at 1 o'clock.
Okay.
So
okay. Everybody's ready for that good briefing for tomorrow. Thanks a lot for reminding us.
Okay, thank you.
Okay. Thanks so much, everybody. We'll consider ourselves adjourned.
Thank you.